Welcome to this explainer. If you've spent any time in a trauma bay, you know the literal chaos that hits when those doors swing open. Every single second counts, right? Well, today we're building a high-stakes survival guide for blunt trauma management. We're going to cut through the noise and look at the strict algorithms and physiologic constraints that will actually save your patient's life. Here's our roadmap for today. First, we'll tackle the hemodynamic decision node, then the fatal CT trop. Move right into the pelvic binder pearl and wrap it all up with dilutional coagulopathy. All right, section 1, the hemodynamic decision node. Let's get right into it. Okay, so to survive the trauma bay, we have to relentlessly separate the signal from the noise. Think about the classic 50-50 dilemma. Is it a catastrophic occult splenic laceration or just an isolated abdominal wall contusion? Now, a clinical lawyer might look at a normal early hematocrit or a soft abdomen during the primary survey and feel pretty good about it. But that is a classic trap. A normal early hematocrit? It's pure noise. It's falsely reassuring because the patient is bleeding out whole blood, so the concentration hasn't even changed yet. The judge in the trauma bay, on the other hand, demands a strict audit of the hemodynamic trajectory. The true signal you're looking for? Persistent hypotension. A systolic blood pressure dipping below 90 is your flashing red light, and you absolutely cannot ignore it. Physical evidence can be helpful, for sure. Take the classic seatbelt sign, for example. Seeing this strongly suggests severe blunt abdominal trauma. It tells us the spleen and liver are at incredibly high risk. And actually, the spleen is the most commonly injured organ here, often right alongside fractured left ribs. But here's the catch. A visual clue like a seatbelt mark only tells us how it happened. It doesn't tell us a single thing about the patient's immediate physiological state. Which brings us to a massive question. How does hemodynamic stability dictate the very next imaging step? I mean, this single physiological question is literally the ultimate fork in the road for our patient. It decides if we're rushing them down the hall to a scanner or straight into the operating room. The algorithm here is the tipping point you've got to commit to memory. Step 1 is always assessing hemodynamic stability. If your patient is stable, great. They go get a contrast-enhanced CT of the abdomen and pelvis to grade any parenchymal injury. But if they're unstable, meaning their systolic is under 90 and they just aren't responding to a 1-liter fluid bolus, they skip the CT completely. They need an immediate fast exam right at the bedside to hunt for free fluid, specifically checking that heparenal or splenorenal recess. Moving on to section 2. The fatal CT trap. What's truly fascinating and honestly terrifying is what happens when we ignore those physiological signals we just talked about. Taking a hemodynamically unstable trauma patient, especially one with a positive fast exam, and shoving them into a CT scanner, it's a critical error. It is a completely dumb mistake to try and quantify a liver or spleen laceration in a scanner while the patient is actively bleeding to death. If they're unstable and that fast shows free fluid, the CT scanner literally becomes a fatal trap. They can easily exsanguinate right there on the table, completely cut off from the immediate life-saving tools of the OR. The guidelines don't stutter on this one. Imaging should not delay exploratory laparotomy in hemodynamically unstable patients. No exceptions. If they're unstable with intra-abdominal bleeding, you bypass advanced imaging entirely and go straight to emergent surgical hemorrhage control. Again, it's all about strictly auditing that hemodynamic trajectory. All right, section 3, the pelvic binder pearl. Let's talk about retroperitoneal hematomas. Because the pelvis is shaped like a ring, severe blunt force usually shatters it in multiple places, causing massive hemorrhage and shock. This specific high-energy trauma creates what we call a Zone 3 retroperitoneal hematoma. To manage this, we use a severity invasiveness matrix. If the patient is stable with a NARM-expanding Zone 3 hematoma, we use mechanical stabilization, like a pelvic binder, and keep a close eye on serial hemoglobins. Emergent with persistent hypotension and a negative intra-abdominal fast, we escalate to extraperitoneal pelvic packing or urgent angioembolization. But if it's critical, like an expanding central zone 1 hematoma, that demands an immediate emergency laparotomy for direct vascular control. Knowing the core differentiator between Zone 1 and Zone 3 is absolutely critical. Central Zone 1 hematomas, which house your aorta and vena cava, demand mandatory surgical exploration. But here's the thing. Surgically opening a Zone 3 hematoma caused by a blunt pelvic fracture, profoundly dangerous. It is a dumb mistake. Doing so completely destroys the body's natural tissue tamponade effect. You release that pelvic pressure gradient and boom, you precipitate immediate exsanguinating venous hemorrhage. So for Zone 3, you've got to rely on external mechanical binding to create that tamponade.
Oh, and a quick vital procedural pearl here. Before you even think about placing a Foley catheter to monitor urine output in these severe pelvic trauma cases, you absolutely must rule out urethral injury. Look out for blood at the urethral meatus, a high-riding prostate, or a scrotal hematoma. See any of those? Stop and evaluate the urethra with a retrograde urethrophy first.
Section 4. Dilutional coagulopathy.
When we are treating catastrophic hemorrhagic shock, our primary goal is dodging the lethal triad: coagulopathy, hypothermia, and acidosis. Mindlessly pouring massive volumes of crystalloids and packed red blood cells into a patient induces a severe coagulopathy called dilutional thrombocytopenia. It's basically a dangerous deficiency of platelets caused directly by the fluids we're using to save them, which then just worsens their intracellular acidosis.
Let's put this into perspective with a scenario. Picture a young patient coming in with a severe pelvic fracture. After pumping in 15 units of packed red blood cells and 8 liters of crystalloid but no platelets, the patient suddenly starts bleeding from literally every single IV and arterial catheter site. Why? Because that massive volume of crystalloids and red cells completely washed out their native platelets and clotting factors.
To prevent this complete breakdown of their clotting mechanisms, your resuscitation has to be balanced. It is a fatal mistake to sit around waiting for formal lab coagulation profiles or fully cross-matched blood before you act on massive hemorrhage. You literally don't have the time. You must immediately kick off a balanced massive transfusion protocol. We're talking a 1:1:1 ratio of packed red blood cells, fresh frozen plasma, and platelets to mimic whole blood kinetics and actually protect those delicate clotting mechanisms. Bringing this all together, here is the major executional pearl that trips up so many people. You have to prioritize mechanical pelvic binding over abdominal surgery when the retroperitoneum is the source of the instability. Remember what we said? Opening the retroperitoneal space in a blunt pelvic fracture destroys the pressure gradient, keeping that low-pressure venous bleeding in check. You must immobilize the pelvic ring architecture first before even considering invasive surgical options. Ultimately, mastering these trauma algorithms takes strict, unyielding discipline. So, the next time you face a critical decision node in the absolute chaos of the trauma bay, I want you to step back and ask yourself, are you truly reading the patient's physiology and treating the real signal, or are you just reacting to the clinical noise?